So these days it's the #1 get-to-go block for breast surgeries. So you have to understand that it would not cover the medial half of the breast. So you need parasternal blocks, which I'll tell you within next 2-3 minutes. So who's doing PEX block? Okay. So will you come forward? आइए आप demonstrate करेंगे मेरे साथ. Please come. So let's make it interactive. Whosoever is doing PEX, come forward. Don't hesitate. Please come. So in order to perform this block, my dear friends, the head has to be rotated to the opposite side. Okay. So this block is generally done in female patients, where the bulk of the breast would be hanging like this. So one of the tips and tricks what you can do is, you can take a leukoplast and strap the bulk of the breast to the opposite edge of the OT table. Otherwise, it would keep coming and just dropping its weight onto your probe. So Dr. Devjani would help us. Linear probe do madam ko. So you start, it's a superficial block, so you'll use a linear probe. Where do you keep it? Just medial to the coracoid process, as you would do for an infraclavicular brachial plexus block. My dear friends, okay? Pec major, minor, 2 vessels, axillary artery, and the vein. Vein would be caudal. Slight medial tilt, the rib visible underneath these vessels would be the second rib. Then the next step is follow the deltopectoral groove and keep going towards the axilla. Count the ribs, 3rd rib, 4th rib. On the top of 3rd and 4th rib, the serratus anterior would become much more bulkier. That is the plane to target the deeper block first and the superficial second. Whenever in the same field of vision you have to block 2 nerves or 2 planes, always do the deeper first. Any reasons? Otherwise, if I do the superficial first, the bulk of the drug is going to push the deeper plane much more deeper and make things difficult for me. Another example is doing obturator nerve. So she has beautifully placed. Right now, her probe is actually placed in the deltopectoral groove. Left hand of the screen, my dear friends, is cranial for her. Okay? So you see 2 muscles, pec major, pec minor, and you can see the pectoral branch of thoracoacromial artery. Can you see the shimmery pleura? The ribs, this rib and this rib. Right now, I am not able to see the axillary vessels properly. So can you come little cranial? Yeah. Thoda sa. So what is happening is, right now, she is little too medial. So what we can do is, come a little lateral, and then we see the vessels. So how do I troubleshoot for any block? I should know in my mind what I expect to see, what I am not seeing, so how do I get it? In my mind, I had this notion that I have to visualize the axillary artery and vein. She is scanning, but from outside I could make out this is too medial because I was not able to see the axillary vessels. Is it clear? Now, the other thing which we can do is, I'll tell you, can I take a probe? Yes, sir. So what we do in our clinical practice is, feel for the head of the humerus, the coracoid is next, keep your probe first in the longitudinal orientation. So classically you would see the pec major, minor and the vessels. A slight medial tilt would bring the rib underneath. This rib would be the second rib. Next is, I am going to turn my probe in the deltopectoral groove and keep following with a slight medial tilt. Okay, second rib. Okay, next 3rd rib. Okay, at this point, can you see the serratus anterior getting little bigger? So this is pec major, minor and the serratus anterior. So my needle is going to come from this place, deposit in this place first, withdraw and deposit in this place. Is it clear? So this I called as a landmark based, surface anatomy based sonography. Is it clear? So in between we'll keep calling you, not to embarrass or you something, it's just trying to give you more finer points. It's not that you are not doing it, it's just to give you more finer points and try to take more finer points from you guys also. At times my technique would not be the best. Okay, so again, medial to the coracoid process, slight medial tilt, the second rib, the 3rd rib as I go, follow the deltopectoral groove. This is your 4th rib. As I keep going down, the serratus anterior is getting bigger and bigger. So what about serratus anterior plane block? Please, you can give me. Thank you. Thank you very much. So serratus anterior plane block can be done in supine position or lateral decubitus. In order to do it in a supine position, what you can do is, you can place the wedge if you require and take a stool, sit back. Again, the bulk of the breast would be hanging now this side. So for serratus anterior, the breast has to be pushed on the other side. For pec major, on towards the hip side. Is it clear? So the things would be easy. So can I have jelly, Shrikant? So the left hand of the screen, my dear friends, would be posterior for me. This is anterior, this is posterior. इसकी jelly clean करते रहना साथ साथ में, ठीक है? So as I place my probe, okay, on top of it, I see a muscle. What is this muscle? Serratus anterior. I see rib, I see underneath, in between, what is that? Pleura. In between two ribs, I see the intercostal muscles. As I keep going posteriorly, I know the muscle on the top would be latissimus dorsi. Why? Feel for your posterior axillary fold. The posterior axillary fold, my dear friends, is formed by latissimus dorsi. I keep going posteriorly. Can you see another muscle coming like a parrot beak? Can you appreciate this muscle? This represents the latissimus dorsi. Underneath would be serratus anterior. In this plane, I would see the thoracodorsal artery. I keep going posteriorly, my dear friends. Can you see a pulsatile structure? So this is the plane for superficial sap. If I deposit beneath the serratus anterior, that means in between serratus anterior and the rib, it would become deep sap. Is it clear? The pecs block are clear, sap is clear. So we'll discuss the indications. Now what about the medial half of the breast? From the lateral sternal margin, इस तरफ फोल्ड करो, मेरी हाथ आना चाहिए. भाई इधर रहो ना आप. Can you see? This is my sternum. From the lateral border of the sternum till mid-clavicular line, the area is supplied by the lateral division of the anterior cutaneous branch of the intercostal nerve, which would not be captured with pecs or sap, which would be captured with thoracic paravertebral, ESP and intertransverse process block. Is it clear? So I need to do a separate. So there are two blocks which have been described in literature. One is the PIFB, the older terminology, between the pec major and the intercostal muscles. Second is the transversus thoracis muscle plane block, which is between internal intercostal and transversus thoracis. The revised nomenclature is the superficial parasternal block and the deep parasternal block. So what do I need to do? Jelly dena, Shrikant. So I'll first keep my probe onto the sternum. Okay. So as I keep my probe onto the sternum, can you see white hyperechoic line? This reflects that I am on the bone. I move my probe laterally on the right side of the volunteer. As I move my probe laterally, keep observing for the changes. Can you see there is a costal cartilage appearing? Can you appreciate? Why do I call it costal cartilage, not rib? Ultrasound beam is able to pass through the costal cartilage, so I see the posterior wall. Whereas if I keep going laterally, more laterally, अभी तक क्या है, costal cartilage है कि नहीं है ये? As I keep going more laterally, the posterior wall disappears. What is this? This is the rib. This represents the costochondral junction, cartilage junction. This is the rib. So I have to get at the level of costal cartilage. The muscle sitting on the top of the costal cartilage is pec major. So my needle can come from cranial caudal, caudal cranial, deposit between pec major and the costal cartilage. As a beginner, as I become more expert, can you see this white hyperechoic line? So this represents the external intercostal membrane. I can come in between the pec major and this membrane because the drug will percolate in this area and the nerves are trying to float like this. And can you see a hypoechoic area? This represents the transversus thoracis muscle. So if I deposit in this plane, it becomes the transversus thoracis muscle plane block, which is the deep parasternal block. We do not advocate, even I do not do it, because underneath, can you see the pulsations of the internal mammary artery? So this block is generally done for breast as well as for sternotomies. If I accidentally injure the internal mammary artery, the surgeon, CTVS surgeon, is not going to forgive me. So is it clear? So where do we do the superficial one? Between the pec major and the costal cartilage, or as an interfacial plane block between the external intercostal membrane and the pec major. Is it clear? So we have covered up till now the anterior half of the chest. Any questions up till now? So should we show you the thoracic paravertebral ITP and ESP block? Anybody who's doing either of these, ESP, paravertebral, just raise your hand.
I think ESP block everyone is doing.
Yes, आ जाओ देवजानी, ये she is like come. चलो, हाँ, वहाँ ready तो नहीं है? बैठ जाओ.
You know, the intercostal innovations needs to be understood for guiding us, for understanding that which block to be used in which surgeries. You know, it is very important. The cervical roots, the lumbar roots, and the sacral roots, they all form the plexuses. But because of the ribs, the nerve roots from T1 to T12, they are not able to form the plexuses, and they run in a single plane. And remind you, just to recapitulate simple facts, that when the intercostal nerve leaves the thoracic root area, it first of all gives a dorsal rami that supplies the ESP muscle and the back of the spine. More laterally, at approximately the mid-axillary line, the roots will give a lateral cutaneous branch, and this lateral cutaneous branch further gives a posterior and an anterior branch. The lateral cutaneous branch will give a posterior and an anterior branch. And these particular roots, or the intercostal nerve, they again come within the intercostal plane, in the same plane, the ITP plane that Sir has shown. And they again give the lateral and the medial branch. The blocks, the PAC1 or the PAC2, sorry, not the PAC1, the PAC2 and the SAP blocks and the wrist block, there is one more block which is called the wrist block, they are made to target the lateral cutaneous branches or the anterior portion of the lateral cutaneous branches. Okay, so are we ready, sir?
नहीं आप करो, बता दो, फिर we'll start. Innovation पूरी कर दो ना.
So if we want to target the anterior portion of the lateral cutaneous branches, then the SAP is the option or the PAC2 is the option. But why PAC1 is not the option? It's more superficial. So there is a clavipectoral fascia that engulfs the pec minor muscle. Okay.
मैं भी कर दूंगा.
All the intercostal nerve, the anterior branch of the lateral cutaneous rami, they are beneath the clavipectoral fascia. Okay. Only the lateral and the medial pectoral nerves, which are from the brachial plexus, which supplies the pec major muscle, they pierce the clavipectoral fascia beneath the pec minor muscle and supply the pec major muscles. That's why the PAC1 or the PAC2 block, they are quite important blocks when they are doing some implants, when they are putting in some implants beneath the pec major muscle. So PAC1 block is given in those cases only. But do you think that the PAC1 or the PAC2 blocks, they are sufficient, or they block the cutaneous supply of the thorax? No. Why? Or which block can block the cutaneous supply of the thorax? SAP block or the PAC2 block, but not the PAC1 block. Okay. Sir, are you?
Okay. So what we are going to right now explain you the posterior chest wall blocks. Okay. So the classical one is the thoracic paravertebral block. The erector spinae, everybody knows. What about intertransverse process block? Anybody knows? Anyone? So how is erector spinae acting? The drug is getting pulled forward towards the paravertebral space through the space between two transverse processes. So anything if we deposit in between two transverse processes, my dear friends, would be intertransverse process block. ये इधर focus करना. So
कैमरा पर्सन आप ना यहाँ पे आ जाइए, आप यहाँ से वहाँ फोकस करिए, वो ज़्यादा बेटर रहेगा. आप अपना कैमरा यहाँ पे लेके आ जाइए. अच्छे से उसका ना हमारा हाथ.
चलो. So let's finish up the scanning, then I'll explain you the concept. So these blocks can be done with the patient in the sitting position, lateral decubitus, or prone position. Right now we are in the sitting position. So irrespective whether you wish to do any of these three blocks, have a scanning sequence in your mind that you are going to scan just medial to the scapula. Okay. The left hand of the screen, my dear friends, is cranial. She has placed her probe in the paramedian parasagittal longitudinal orientation. So the structures which you are seeing on the top is skin subcutaneous tissue. The muscle is trapezius, okay? And underneath what you are seeing right now is the rib. Why do you call it rib? Rib is round, quite superficial. So next step she is going to do is move towards the midline. Then next what we'll see is the articulation of the rib with the transverse process, because costo-transverse junction will come. So she will keep moving medially slowly. As she keeps moving medially slowly, please keep moving, please keep moving. You are seeing a muscle is getting bigger and bigger. This represents the erector spinae group of muscle. It is not a single muscle, it is actually 3 muscles. Keep moving slowly towards the midline. Yes, midline, yeah. Can you increase the depth, please? Yes, more midline, more. So I think we have reached the midline. थोड़ा सा और lateral शुरू करो. आप यहाँ से शुरू करो. यहाँ से शुरू करो. Okay. So can everybody appreciate the ribs, the pleura, the intercostal muscles, the external intercostal, internal intercostal, and the innermost? Beautifully seen. This is Mercedes Benz. Not with this standard sonocyte machine you would be able to. Now she is moving medially. Okay, very slowly, with keeping rib in the center. Yeah, very nice, Devyani, you are doing a good job. Yes, very nice, very nice. Thoda sa. Can you see the contour has begun to change? Now it will become almost square shaped. Transverse, yes, almost it has become transverse. Can you get it into the center? इसको नीचे ले, yes, और नीचे लो, और थोड़ा और medial चले जाओ, और थोड़ा medial, yes. Can you see 2 bony lumps? We have reached the costo-transverse junction, my dear friends. Can you move a little more medial? More medial? Yes. Now it has become a perfect square shaped. So this is the level of transverse process, and if I get my needle from cranial caudal, caudal cranial, deposit between erector spinae and the transverse process, this would become the erector spinae plane block. Thank you very much. Okay. Now I'll show you the other 2 ones. Just ऐसे करो. Okay, my dear friends, starting from rib. Okay, you are seeing 2 muscles. Can you appreciate? I am on the top, trapezius and rhomboids. Concentrate on this muscle as I go medial and medial. Okay, as I go medial and medial, this is getting thicker and thicker. This represents which muscle? Erector spinae. At close to the scapular border, erector spinae is not present. What I am seeing, 2 muscles, trapezius and rhomboidus. As I keep going medial, keeping it in the center, I see the muscle getting bigger and bigger. Can you appreciate? So this represents my erector spinae group of muscles. And I have almost 2 bony humps. Can you see the square shaped structure? So this represents my transverse process. Right now I am seeing the shivamri pleura. I do not see the superior costo-transverse ligament, which represents my posterior boundary or the paravertebral space. So what I need to do is 5 degree outwards. If I turn my probe, I'll be able to see that ligament. Can you appreciate that beautiful ligament? Can you appreciate? आप इसको freeze कर दीजिए, please. Okay, the left hand of the screen, my dear friends, is cranial. Right hand is caudal. Can you see the hump? You see 2 humps. I'm almost looking at the costo-transverse junction. And I see the pleura. I see white hyperechoic line which extends from the rib below. We are ready? Which extends from the rib below to the transverse process. We'll carry forward with this.